fragrance to calm your head.
Okay.
Okay, good afternoon to all. Thank you for making the time for being with us today here and online. On behalf of the Health and Development team, the Gender team, and the Innovation platform of UNDP, welcome to this groundback launch on co-financing for gender-based violence action plans and SDG accelerators. We're pleased to have with us here in New York Michelle Rem and Fatima Ghani from the United Nations University International Institute for Global Health. And this institute is based in Kuala Lumpur and is part of the UN family. So we're very pleased to have you here today and have this collaboration, which you will present this morning. You have the biographies, the short bios of Michelle Rem and Fatima Ghani. Michelle Rem has been working with the UN and sometimes for the UN for quite a while, and is now leading the research pillar of the UNU Institute for Global Health. And Fatima Ghani also has some experience in working with the UN and is now working with Michelle Rem on the SDGs. And of course, the SDG 5 is an important area of focus for you. So UNDP has worked with Michelle Rem in previous occasions, and the last time we worked together, it was to publish a paper with the ambitious title of Rethinking Financing for Addressing Gender-Based Violence. So I don't know if we were able to rethink how we finance the policies to address gender-based violence, but at the least we laid out some interesting ideas that were discussed and that served also as the starting point for a project that is now being implemented by UNDP on the linkages between SDG 5.2, which is the target to eliminate violence against women, and the other SDG targets. And you know that many of the SDGs will not be met unless we do something meaningful on ending violence against women. So this project, funded by the Republic of Korea, is now alive and kicking, and has benefited from that dialogue, that initial dialogue with Michelle Rem on, first of all, looking at the different ways of allocating funds to GBV policies and actions, and also in involving new actors, right? And not always looking at the traditional ministries in charge of ending gender-based violence, but involving non-dedicated GBV actors, such as the Ministry of Finance, of course, but also the private sector, the civil society organizations. And now we are partnering in the implementation of this global project. And the global project has a specific focus on financing at the local level. That's where we see the most promising areas of work when it comes to bringing together the different actors and look at what is needed in that specific locality to prevent and address gender-based violence. And the project brings different elements of financing and costing and value for money interactions to make sure that the participatory process at the local level incorporates that aspect and can lead to more sustainable funding for GBV at the local level. So this morning in New York, Michelle Rem and Fatima Ghani will present some of the work being done at the field level through this project. We're going to talk about innovative participatory planning and paying at the local level. And they will also make the case in less than 1.5 hours for cross-sectoral co-financing with multiple impacts across the SDGs, which is music to the UN's ears, because we're all about accelerating efforts to meet the SDGs, and UNDP recently launched its accelerator labs all over the world. So I hope this conversation will be useful also for that work. And without further ado, over to you. We will let you present, and then we will open the floor for questions coming from here, but also from colleagues participating online remotely. Thank you.
Great, thank you very much. Thanks, Diego. Thanks for the introduction, and thank you all for being here. Thanks for having us. We're very excited to be collaborating with the gender team, and also I've worked before with the health team. So it's nice to have this cross team meeting, which will reflect some of what I'll be presenting as well. So I should be using this, right? Thanks. So yes, a slightly ambitious title. So co-financing for GBV action plans and the SDG accelerators. Here's a brief outline of what I'll be presenting together with my colleague Fatima. First of all, just because I'm not sure how many of you know UNU-IIGH, I didn't before I applied for the job, so I thought I'd give you a bit of an introduction. We're also in a new phase. We have a new strategy, so just to tell you a little bit about that. And then I just I thought actually it made more sense to start to present kind of the concept of co-financing, which, as Diego mentioned, did spur some of the thinking we had a couple of years back on rethinking financing for GBV, and then from there to go into this planning and paying model that we're working with the gender team on for local action plans for GBV. So that will be presented by Fatima, and I might pick up some of the economic pieces at the end. So yes, hopefully very briefly on, oh, sorry, I have two things I need to work with here.
I can do this one again.
There's some animation I need to. So yeah, so UNU-IIGH, so the United Nations University, which I think many more you might know, is really was set up a long time ago and was meant to be a bridge between academia and the UN system and member states, and it's supposed to function as a think tank. It has 14 research institutes under it on different topics, and we are the one that focuses on global health. So we see ourselves as the UN think tank on global health. We were established back in 2005 with an endowment from the government of Malaysia. So that's how the institutes work. Governments offer to host them, and then they provide an endowment. So what's nice about that is it gives us some core funding, but it also means that we're independent and we're non-aligned. So it allows us to take a more neutral position on certain things. And really our aim as UNU-IIGH is to build knowledge and capacity for decision making by the UN agencies, programs, and member states on issues related to global public health. So here I just want to summarize a bit. We've just done our new strategy, and we have a unique value position, which anyway, can be summarized neatly like this. It's really this idea that we are within the UN system. We have our UNU network, so we have a lot of colleagues in other institutes with expertise. You might know WIDER, which is a more known one on development economics. There's another one, governance. We take an interdisciplinary approach, which I know UNDP does as well. And we're located in Malaysia, and we have a lot of links in the region. So just to highlight, we're obviously not competing with academic institutions or UN agencies. We can't, we shouldn't. We really see ourselves as a resource within the UN and an interface between academia and UN policymakers. So here is our strategy, very briefly. We circulated a brief, but just the usual ones, kind of high-level goal. But I just wanted to speak a little bit about our objectives and our pillars there. So we have 3 pillars. The first one is on translating evidence to policy. The second one is on generating policy-relevant analysis, and the third is on strengthening capacity for local decision-making. I'm sure this reflects a lot of agencies' high-level objectives, but it does get more specific. How we do that is we host fellows. We have fellows, PhD students, and other experts that sit within our institute. We have a network of experts. We partner with, like in this project, we partner with UN agencies. We advocate, we disseminate, and we, of course, monitor and report. We're supposed to report up to the Secretary General. So specifically, just so you know what you can expect from us, in terms of translating evidence to policy, the main function there is a convening function. So the idea being, we have a lot of global guidance, global recommendations that struggle to get translated into local, relevant, actionable actions, and actionable recommendations. So we see our role as we offer a function where we can bring together both the academics, the experts, voices from the global south, which are often missing from some of these dialogues, and we would love, would attract people to come to Malaysia, and we can host these functions. Really, the idea being, a bit of like a Chatham House type thing for global health, where we can, we're content agnostic, so whatever topics are brought to us, we can take this, we can do the background evidence reviews, we can provide the materials that go into a meeting, find the right people to come around the table, and then provide the support in terms of outcome materials as well. So if you need something like that, you can come to us. The second piece is on generating policy relevant analysis, and just very relevant to our discussion here is our focus for the next 5 years is on gender and health, because it's a clear gap that's been identified, and it's something that we have expertise in-house on and can contribute to. So that's a big part of our work. And the last is on strengthening capacity for local decision making, which is really about using the fact that we're in Malaysia, and Malaysia has a very strong health system, using that as a space to provide or support South-South engagement and provide a South-South learning hub, really, based in the region, to bring decision makers from low and middle income countries for capacity building in a range of trainings, and we also develop knowledge products. So I'm going to stop the pitch now, but just so you know, now you know who we are. And I'm going to go on to the co-financing piece. We were told we had about an hour. We thought that might be a bit too much of us, but then we started putting slides together, and it might actually, we might get there. But I speak quite quickly, so it might be okay. So the background is what Diego mentioned, and all of you deal with on a day-to-day basis. The world has adopted these very ambitious, interrelated, interconnected SDGs. I think many of us feel that they're a better representation of the complexities of development and of the issues that we face in our day-to-day work, and this is the way forward. But they do not necessarily reflect the reality of how governments are organized, how development institutions are and international institutions are organized, and how they operationalize their work. So the reality is we do function in these operational silos, and we shouldn't forget that these vertical approaches have been very successful in certain areas and have managed to achieve some pretty remarkable progress in the past 10, 15, 20 years. But there is a very real risk of missing out on the synergies in between these vertical programs. And I think with the 17 SDGs and a price tag, which is over an additional 1 trillion per year, just looking at low income and lower middle income countries, we obviously cannot afford these inefficiencies. This is the starting point. And one way to look at the inefficiency that can result from this siloed approach is, I just want to illustrate that with this example of a cash transfer in the HIV sector, or in the HIV world, which was quite a hype at some point. And that's when I worked with Roy and his team. Essentially, the World Bank supported the government of Malawi to do a study in Zomba, in a small rural area in Malawi, and they provided a cash transfer to adolescent girls. And the scheme was provided both to the girls and to their guardians in kind of a mixed approach. They got about $10 a month. Some of it was conditional. Some of them got a conditional grant, others were unconditional, but that was not what it was looking at. What was remarkable is that after just 18 months of implementation, they found a whole range of outcomes, which included education outcomes, early marriage reduction, HSV2 reduction, teen pregnancy reduction, and a reduction in HIV risk. Just to be clear, this intervention was really just getting those girls in school. So there was no HIV component. But the team looking at it was taking an HIV perspective, and they looked at this and they basically compared the full cost of the intervention to that HIV outcome, and estimated that the cost per HIV infection averted was between $5,000 and $12,500, which if you would compare it to any other HIV prevention mechanism, kind of intervention, it didn't compare favorably. So the conclusion from that study was, well, this is a nice intervention, but it's not cost effective from an HIV perspective, and therefore HIV resources should not be allocated to something like this. Now, the problem with this is, problem with this is that you can end up basically paying a lot more for the same resources just because of the approach you're taking. So the HIV, budget holder or payer in this case might say we can achieve the same outcome, so the 64% reduction in HIV risk, by doing something else, which will cost us half the price, right? So let's do male circumcision, it'll cost us half the price. These are just illustrations. The education sector might say, I can also get the same outcome, and I'll build sanitary facility for girls at half the price. Gender, if they had money, could then raise awareness among traditional leaders at half, again, at half the price. We get, so in the end, and kind of sexual and reproductive health could also do something else at half the price. And each sector would have ended up paying less for their outcome. But overall, as government or society, we would have ended up paying double the price. And this is just an illustration of really what is this inefficiency that we're talking about. So then the question is sort of, why are we, not funding these things? And I think there's some very real things that would resonate with a lot of you, and having worked in country context, is this idea that, well, investing in these kinds of interventions gets limited funding because they're considered to be beyond the remit of the funder in question, right? The HIV sector, so this is just a study that was done in Tanzania among HIV policymakers. They said, HIV money can't be used to solve development problems, broad development problems, poverty eradication. That's not our mandate. Also, this issue of complexity. These things are complex. They're long processes. They're large-scale programs. The HIV budget can't be used to fund a kind of large-scale cash transfer program, for example. And then, of course, the issue of accountability, right? So we're accountable to what we spend our HIV monies on. We need to show the HIV outcome. And really this idea that this focus on proximal determinants, so really things that have direct impacts on our outcomes of interest, and not being able to consider the broader externalities that are beyond our area of focus. And so the challenges with taking a multisectoral perspective are that single sectors are really trying to maximize at best one or two outcomes. From the health payers' perspective, what we find is that they want to improve health by implementing interventions in the healthcare system, usually. And the problem with that is multiple sectors contribute to health gains, right? So you might, especially when you're trying to address the social determinants of health, but those other sectors, they're not primarily trying to maximize health. At the same time, goods and services produced by the health sector can have externalities and spillover benefits beyond the health sector. But the current approaches we use when we think about value for money or cost effectiveness don't acknowledge these spillovers, and therefore you could end up undervaluing investments in, here we can call them upstream social determinants or SDG accelerators. So we did this study. I just want to show you a bit, building on the Zomba example. We kind of illustrated how we could take another perspective. Essentially, the point of that study was to say if HIV resources could be used to co-finance these kinds of interventions together with other benefiting sectors, you might end up with a different outcome. And then when you think about value for money from an HIV perspective, you would only consider the HIV sector's contribution, not the full cost of the program. So what we did is, and I will spare you the details of the methods, but really we tried to explore to what extent maintaining the status quo, so using kind of HIV sector-focused cost-effectiveness rules, could lead to suboptimal financing decisions, and explore whether there might be another way to do this. So from that same example I just showed you, we essentially tried to estimate what was the impact for each of these different sectors, what is each of them willing to pay for that impact, and therefore what would they be willing to contribute into a pooled budget to actually get something like this implemented. So for an HIV, I'll just do the first line and then just as an illustration. For the HIV case, this intervention managed to avert 6 HIV infections. Just a reminder, this was a small study. It was 1,200 girls, but they managed to reduce HIV infections by 6 of them. And so you could translate that into disability-adjusted life years. which is about 94. And then we use the willingness to pay there from basically assuming that it's worthwhile to invest in preventing it or averting a disability-adjusted life year at a cost that's below your GDP per capita. That's kind of a rough estimate. And that would end up having HIV put in 29% of the cost of the program. What this shows here really is just, if you focus on the last two lines, is that if each sector went through the same process and estimated how much they would be willing to pay for this, none of them would be willing to fund this program on their own, taking a siloed approach. But if you would consider a mechanism by which they could co-finance, you could add up their contributions and that would go over and above the cost of the program, which means that actually you could get this implemented and you would even see cost savings to some of the payers who could reap that difference. So this is a different way of illustrating it, and this is from your colleagues here at UNDP, which is, if you have a program, each sector's willingness to pay might not add up and program won't be funded, but actually, if you're willing to co-finance, this could be a solution to actually generate those benefits across sectors. The conclusion from that study was that with a siloed approach, your interventions with multisectoral outcomes could be underfinanced, they could be unfunded, they could not be taken to scale, and co-financing is an opportunity to realize these synergies. But, and it's a big but, I'm sure for a lot of you who've worked in this and tried to work in spaces where cross-sectoral coordination is needed, it's a very tricky thing to achieve. It requires strong cross-sectoral negotiation, coordination mechanisms, and often the institutional incentives that are there hamper this type of coordination and joint decision-making. And so we obviously highlighted the need for more research and a better understanding of what were the barriers there and also what were potential enablers. But the bottom line, I think this is important, is that what we were saying is that if you only consider one outcome when you're thinking about the economic value of an intervention with multiple benefits, is you could provide incomplete evidence to policymakers, and you could actually lead them to make the wrong decisions, both from your own sector's perspective as well as from the broader societal perspective. And so this was that study. This was back in 2014, and every time we'd present this, people would say, well, that sounds lovely, but this can't be done. Sectors won't agree to pool their resources. And actually, went and looked a bit at the literature, and I just want to say we've done a review, and these are preliminary findings, but there have been cases of co-financing. These things have actually been implemented. So this is, we did a systematic review and we found 65 cases, mostly in high-income countries, mostly with the health sector, but there are also with social care, education, justice, and housing. Most of them are involved two budget holders. And here's a list of some interventions, the types of interventions that have been co-financed. So things like school health and nutrition, road safety initiatives, health and social care, there's a typo there, mental health promotion, and so those are the types of interventions we found. So it can be done, it's institutionally feasible, but it's not straightforward, and it's definitely not without challenges. Again, we did a study in Tanzania, speaking to policymakers and asking them, and this was not just for HIV, this was broader, asking them to identify what were the main barriers and enablers that they saw in their landscape for such an approach. And just to highlight a few, I think in terms of enablers, it's quite clear you need high-level buy-in, political will, that thing that keeps coming up. You need champions. But you also need evidence to show that there are actually clear gains in terms of benefits, but also in terms of cost savings for the different sectors. And the barriers that came up were, the fact that a lot of these sectors are working with very limited resources themselves to provide their own services. So they don't have space. They don't have the fiscal space to start to redistribute. And obviously, you could argue that they would still get efficiency, so it still would make sense. But obviously there's quite some resistance there. And again, that resistance is also linked to the resistance to lose power or lose control of your own budget, which is often a big driver and a big objective of a public sector. So that was one study we did, but I just want to summarize. The literature actually highlights many of the same barriers. So the fact that they're, especially in low and middle income countries, they're very limited discretionary budgets. A lot of the budgets are already earmarked or allocated. They have limited, I don't know why this is coming up right now, I'm just going to put it off. They have limited financial autonomy in many cases. This fear of losing control of their budget is a big one. There's a potential risk of it being misused when you allocate it to another sector, but also just this loss of visibility and this, you're not able to justify your existence anymore, and therefore you can't mobilize additional resources because you can't demonstrate that you're the one who did that, and obviously the issue of attribution. But also, obviously, the co-financing idea in theory is very much based on the idea that each sector is actually trying to maximize outcomes. In reality, resource allocation is often based on outputs, services, and outcome-based financing or budgeting is still, I think it's not really materialized yet in most contexts. The enablers that keep coming up are, there's evidence of mutual gains, cost savings, strong political will, the need for governance mechanisms already there that are intersectoral, that can facilitate and ensure accountability, very importantly. And decentralization, that's really important point linking on to the discussion, is really, it keeps coming up that actually there is maybe more potential at a decentralized local level where the silos are less pronounced and decision makers are more focused on a population as they're trying to make a change for a population, and possibly more so than at the more national level. The same was found for payers that have a strong results focus. So, for example, in the health space and HIV specifically, there's a very big, donors tend to have a very strong focus on results. So there might be more potential. And again, another point that came up, and I think is important to the project we're doing together, is that actually you do need the seed funding there to actually catalyze this intersectoral action. Often that has been an enabler that really pushed things forward. And I just want to speak very quickly, and I'll let Roy tell us more about it later during the discussion, but so some of the work we did before has now led to a guidance note on co-financing, which is about to be released.
Yes. Coming soon.
Coming soon. Watch the space.
Ready to retweet.
So it provides guidance on what is on the approach as a new way to budget for interventions that deliver benefits across SDGs and SDG targets. Its focus is on applying co-financing to public budgets, obviously in the context of the Addis Ababa Agenda for Action and the focus on domestic financing. And it presents co-financing as one solution among, obviously one particular solution to SDG challenges, but among many others that are needed. And the target audience is public sector planners, economists that are supporting government's plan for the SDGs and UN country teams. And one opportunity I think that has been highlighted there is sort of the MAPS approach and using that as a way to deliver and maybe scale up co-financing. I won't go into the whole details of the guidance note, just to say that it really does focus on providing some concrete steps of how you would get started with this and how you would do it. And it provides some real world applications of where it's actually been done. And Roy will tell us more about that later. So I'm just going to end there. I really just wanted to give you a bit of a flavor of what was the thinking behind this cross-sectoral co-financing? How did we get here? This was work that we did kind of with UNDP, but it was also, I used to be at the London School of Hygiene and Tropical Medicine, and it was under a research consortium we had, which was on tackling the structural drivers of HIV, which is why there's quite a lot of focus on HIV. But I think, as you can see, it's relevant for health and for definitely beyond health as a concept. And it really is about, trying to identify these sweet spots, these accelerators, and then thinking about how you pool resources to fund them. And I think gender-based violence prevention and addressing it has come out as another very strong area as an accelerator. And that's where we have been working together with Diego and his team to sort of try to see how we can apply some of these principles really down at the local level in terms of planning and paying for such local action plans. So I'm going to hand over to Fatima to take us through a couple of slides on that.
Hi, everyone. So we are now going to talk about the specific project that we are co-financing with UNDP. on planning and paying for local action plans to address gender-based violence. Okay, so just to give you some background for those people who are not working in the gender sphere, gender-based violence is highly prevalent in the world. 36% of women worldwide have ever experienced gender-based violence. So it's a big problem that is also generating large health, social and welfare and economic cost for women and also their families and communities. And we know that the key drivers of gender-based violence are unequal gender power relations. So this is a model, it's a multi-level model that is showing, the center shows the individual, but the individual doesn't operate in isolation. It operates in an environment. So the theory is that if you focus on individuals, you will have limited impact on decreasing the prevalence of gender-based violence. So if we look at the different levels in which we could operate and intervene, then there would be working synergetically towards transforming gender inequality. So, for example, community-based interventions could actually have a bigger impact than just focusing on responding to survivors first. So we know that despite the gender-based national gender-based violence plans in many lower and middle-income countries, these initiatives are severely underfunded. The single sector responsibility for planning and budgeting, many focus on response and not prevention, and they lack local ownership and resourcing of plans, which is actually impacting on the gender-based prevalence. It's not really going down. So we have a collaboration with UNDP, UNU and UNDP in this global project called Ending Gender-Based Violence and Achieving the Sustainable Development Goals, which is currently funded by the Republic of Korea. And it draws on the experience from UNDP on local governance and also UNU-IIGH expertise in costing interventions and promoting innovative co-financing strategies. So this is very relevant to Pillar 2 that Michelle presented earlier of our strategy, which is generating policy relevant analysis, focusing on better resourcing of gender responsive approach for health impact. So first of all, we just wanted to break the title down into different parts for those who are not familiar with it. So what is planning and paying for local action plans? So it is an innovative, multi-layered and multisectoral approaches where we engage the local community, local key stakeholders into designing a plan that is locally relevant. They decide on their own priorities and their own responses. And everybody would be working towards transforming unequal gender power relationships at the local level. This is the first time that these co-financing models are applied to resource local gender-based violence plans. Previously, they had been trialed in high-income countries to address the needs of high-need groups, the needs of multi-needs groups. Okay, so why is this approach important? Oh, we strongly believe that these local action plans that address gender-based violence can accelerate progress towards the Sustainable Development Goals, because gender-based violence drives many of these goals as well, and they are interlinked. So engaging local stakeholders, such as survivors, and attaching the service to those that are most needed also is in line with leaving no one behind. and supporting local communities to define contextual priorities and solutions are very relevant for local engagement and empowerment. And most of these services are occurred at the local level. So we are basically saying that local stakeholders are the experts in their area. They know their context very well, so they should also have a say in what responses should be implemented. So why is it important to co-finance the labs or the local action plans? This is, as my colleague explained earlier, this is a much more efficient allocation of public and private resources. There are benefits of reducing gender-based violence that can be shared across sectors, and the risks are minimized for each payer. And sharing the responsibility and ownership can be more flexible, more coordinated, and sustainable and accountable. So this project overall has selected 7 locations across the world. These locations have high gender-based violence prevalence, and they cover low and middle-income countries. So the locations are Peru, Indonesia, Moldova, Lebanon, Uganda, Iraq, and Bhutan. So UNU is costing 5 of these. There are 3 participatory plan pilots and 2 integration pilots. The 2 integration pilots are Uganda and Lebanon. So they are part of a bigger project, but we are focusing here on 3 participatory plan pilots, which we developed a briefing note to guide UNDP country offices. So these pilots are based in Indonesia, in Jayapura, the district of Papua, the Republic of Moldova, in Chersoba village, and Peru, in Villa Salvador, which is the district of Lima. So in this briefing note, which is kind of a guide of how to, we explain the steps that need to be followed to be able to design and implement the plans. So first of all, there is a situational analysis that would be done, which identifies the local needs, strengths, and key stakeholders that need to be involved and engaged and brought to the table in order to design these plans. And they would surely include survivors, so the victims themselves, but also women's groups, which would be the most relevant to bring to the table to help this self-determination. Then the next step is participatory planning, which covers the fact that it would be more of a bottom-up approaches rather than top-down of setting priorities, local priorities, and is aligned with the local government planning cycles. The next step would be the implementation of the local action plans, which the activities would need to be prioritized and also implemented and integrated. So these activities would not only cover prevention, but also not only response, but also prevention, so that it would be more integrated type of service. And then the last step would be, well, monitoring and evaluation as well, to see what activities within the program can be fine-tuned and what can be scaled up or perhaps replicated in other settings. Yeah, so I'll just hand over to Michelle from here.
Sorry, got me again. So this is looking at the second component. The model is to be a participatory planning and paying model. So we shouldn't actually be presenting the paying side separately, because it is really meant to be an integrated process. But there are distinct steps within the paying that are worth laying out in this way. I just want to say that it's really important to have that costing and financing as part of the planning process, because what tends to happen is, we have aspirational plans that are designed, and then someone says, oh, you need to cost it. So then we cost it. And then we realize there's a funding gap. And then actually we've gone through a whole participatory process to get these plans drafted. But then when it comes to allocating resources, the prioritization tends to be done in a more ad hoc manner, and definitely less participatory manner, among a smaller group of people, who then say, okay, this is how much we actually have. So which activities and which interventions are we going to prioritize? So you've invested in that participatory process, but when it actually comes to it and what actually gets implemented, that gets missed out. And I think that's why we really want to make sure that the costing and the financing considerations are taken into account early on. So that means you draft the plan, and then you need to map out, okay, within that plan, what are the expected activities? That helps you cost them. What are the expected outcomes? Which then helps you identify who are the payers that might be interested in these outcomes. So if I expect an education benefit, if I expect it's going to reduce, judiciary costs, who are those different payers and sectors that we need to bring to the table? And we can then attract them, through this co-financing argument, but really trying to show to a range of sectors that it would be in their benefit to finance these plans. And this is why. This is the value for money they would get out of it. And this is prospective, and this will be a bit of, more modeling and less, you wouldn't actually have the outcomes yet, but it's to get people to the table. And then when you actually have a sense of how many, what are the actual resources that are available, then you need to go through that process of prioritizing based on the real resource envelopes that you're dealing with in a participatory manner. So for this project, but in general, if you would want to go ahead with this, you'd need to, we've developed a costing tool. It's adapted to each pilot and collecting data on direct and indirect costs. And there is quite a focus on trying to think about the cost drivers, because, going forward, if this would be replicated or potentially scaled up, what is likely to happen to the costs. And then we're trying to think about value for money, retrospectively, looking back. And I think one important thing is, one important bit we're trying to get at in the research is we'll use the value for money to attract different payers to come and co-fund the local action plans. But also, then looking back, we do have a hypothesis that we're playing with, where we expect that these participatory planning and paying plans will lead to, first of all, better plans. We expect, because it's participatory, you'll have better plans. They'll be more comprehensive, and they'll be owned and better implemented. And secondly, they'll be better and also more sustainable, because you've brought these different stakeholders, and they're actually going to continue providing these resources going forward. So trying to test this hypothesis, we want to analyze and kind of compare the cost of the model to things like the number of payers, specifically non-traditional payers, that get involved and get kind of crowded in to pool their resources into this budget, and also the volume of financing that will be mobilized from these sources. So beyond the UNDP resources that are coming, what are the other sources that will be brought in? And that, I think, will be our measure of success. This is just a summary slide to sort of say what we expect to be the benefits of this planning and paying model will be to enhance the governance and the capacity of local institutions, enhance resource mobilization and accountability, because once you're putting money in, you do want to know what's happening with it, and also it allows for local communities to hold different funders as well, different service providers accountable. Here we include the private sector. And then obviously GBV integration within, the idea would be that this would really be integrated within local planning and budgeting cycles. And going forward, this would be more sustainable, hopefully, and it would, be able to go past this kind of the electoral cycles that tend to drive some of the financing of some of these plans and other plans in general. So I'm going to stop there. Just to acknowledge all our colleagues in the gender team and in the HIV and health team for some of the co-financing work. To apologize for any incoherence. I just arrived this morning after a 24-hour flight, so I'm a bit groggy. But hopefully it provided some overview of the work that we're doing with all of you and with many of your colleagues at least. And look forward to your comments.
Thank you, Michelle. Not only was very coherent, but it was very inspiring and I thought also very rich. So I will open the floor for any comments, questions, anxieties triggered by the presentation. Do we have people online maybe?
No.
Okay, so if we don't have questions now, maybe Michelle and Fatima, you could provide a concrete example using one of the pilots, like the one in Indonesia or in Moldova, about what we're doing and how we are gathering the evidence about the costing experience, the money for value exercise to scale up the intervention.
Sure. So it's still early days, right?
Yeah.
We're still in the first couple of months of the project. I don't know if you want to speak a bit to Moldova, but just to say, I think one very interesting pilot is the Indonesia one, especially from a financing perspective, where this issue apparently seems to be more that they have funding. So they have multiple funding streams that are coming from kind of the national level, from the provincial funding, provincial level, and from village development funds, as well as Islamic banking, I think was the other source. But the issue is that, there's at the moment, no way of kind of coordinating how we tap those different funding streams to actually fund gender-based violence plans. They have a strong national level plan, and again, the issue of kind of translating down to the local level is there. So we are going to be we are already kind of working with the colleagues there, but we are going to go soon to actually really get concrete about it, to really map out these funding streams and kind of what's their volume, what are the constraints and rigidities around accessing those different funds. And basically, based on that mapping, we'll try to provide some mix of options for them to consider where they could try to draw resources from and how they could advocate and use those different funding streams to actually fund their plans. So at this point, it's still, it depends what we find there, but that's sort of what we're aiming to do. And I think it's interesting because a lot of in other contexts, it tends to be a lack of funding, and then you need to be thinking much more creatively about where you can get the money. But in this case, there is a lot going on. So it's really about making sure we really tap what's there.
In the case of Moldova, so the context is quite complex in the sense that there is a location that is multi-ethnic and multilingual. So the area that was chosen is in the rural area. Is highly disadvantaged. They don't have many resources. They speak Russian, which is quite different from Romanian, which is spoken in the capital. So they identified. Well, first of all, they created a multidisciplinary team that involves teachers, nurses, social workers. They identified that they didn't have the skills to deal with the gender-based violence cases, and they identified that they lacked a social, actually a physical environment, a safe space. So what we had been doing is trying to build their capacity, so providing training along with Erin, who is a UNDP consultant in gender-based violence. So we've been looking at what the national guidelines are and how they can be adapted to best fit the local context. So they are, with that information and through workshops, they are able to come up with a strategy and the plan, basically, to address what the community requires. In terms of the safe space, the initial funding with the UNDP, the local governments has been able to donate the space, but it needs to be refurbished. So that is going to be a mix of UNDP funds, but also crowdfunding. So as you can see, there is the community who is trying to also be engaged and at the wider level into addressing these issues from the financial point too. So the safest phase is expected to be ready towards the end of this year. But in the meantime, the multidisciplinary group is actually started seeing cases, and they feel better equipped to deal with the cases now.
Thank you. Can I please?
Hi. I think with regard to co-financing, there's an important role for civil society or community and communities, however we look at them, to both hold them accountable, but also to make the case with the relevant payers for why some of these funds should come from their budgets. However difficult it is for the budget holders to immediately see the connection to it. The challenge I've seen in my experience is that oftentimes communities are also very silent in how they look at gender-based violence. Oftentimes the intersectionalities with education outcomes, health outcomes, the case we make with the SDGs aren't immediately apparent, especially with the ones who are traditionally empowered to hold states and actors accountable. The communities that suffer, they can tell you how it impacts on them. So I'm just wondering, one, if that is factored into the planning of this pilot on the projects altogether, and whether that's what you're trying to do with these multidisciplinary platforms in the way they're conceived.
Yeah, I think one big part of it, and yeah, sorry if that's not articulated enough, is really that advocacy piece. So really to use the evidence that we get to make the case to these other payers that, based on at least some evidence, maybe some modeling to show this is what you can actually gain. I think it's worth noting in the gender-based violence space, a lot of the work, the economic work, has been about showing the costs, the kind of social costs of violence, and sort of, what are the costs in terms of productivity, lost productivity, in terms of legal costs, and so on. And that can be part of it. That can be part of showing, a justice sector or other sectors, show them these are costs that you are incurring. If you would address this, these are the costs. Basically, would be cost savings you could get. So that's a slightly different angle. But yes, it's definitely. And in Peru, that is actually something that's going to be done. The cost of inaction. So both pieces can help to make that case, and I think it will be a huge part of it. It's an important part. At least we see it as an important part of this project. Is really to make that case, to use the evidence we get to make the case to different payers of why they should come to the table. And I'm not sure how successful we'll be, but that's the aim.
If you allow me to chip in, when we were designing the project, we knew that the costing argument would be a powerful argument to spur political will, right? Because you saw that's an important component of why governments are doing something or not enough to end violence against women. So we are very aware that this is only one element for the discussion and to ensure political will. So that's why the project also covers other aspects, So we try to involve political actors. When we were in Moldova, we had a very fruitful conversation with the parliamentarians for them to know that this is happening in Kosovo, and they will have the financial arguments to make the case for scaling up the intervention, but also we will speak their language in terms of the political incentives, right? And when you're talking about political incentives, you're talking about partnerships with civil society organizations, both in the field, but also at the national level. So it's really building coalitions and using these financial arguments and the costing of the intervention as a very compelling pieces to spur political will. Any other questions? I see Ludo is pensive. No questions from there. Maybe online?
This one.
We have a question here from Richard. So do you also have an example of a project that we could use to guide our project development process? There was a mention made of a project I funded by Korea, for example. So I'm not sure I understand. To guide our project development processes. Richard, maybe you can clarify your question. Esuna, please.
I'm actually not so convinced, to be honest, about how effective is this cost-benefit analysis for incentivizing governments. And as you just said, like, you can provide evidence to policymakers, but then ultimately, the way they implement, it's just like you wonder where all this evidence analysis went into. So what was the whole point of it? So, and there are different factors that can affect the implementation process that go beyond our control, and sometimes even progressive thinkers or policymakers that do see a value in that. But like when you mentioned in the slide that ultimately the GBV, different forms of GBV, they ultimately rooted in power relations, right? In those gender norms. And I just wonder what incentives beyond economic incentives can you think of to address those root causes? This is where I guess but what are these incentives for the governments? First, I think it's so difficult to address those so deeply embedded norms. Like it just takes, I think, generations. But then what kind of incentives you can use to accelerate that beyond this benefit cost analysis, which I see value in that, but I don't have much faith in that.
I understand. I don't think I have an answer for you, but I would just say, I think that's the case of evidence-based policy in general. I think we still, it's still important for us to, as much as possible, try to drive that and to provide evidence to drive that. But yes, it's not always followed. It's often not followed, rather. I think always with costs and cost effectiveness, cost benefit, it's always important for us, as health economists, we always see it as one piece of the decision-making process. It's by no means the most important piece. It's one element that is meant to inform those processes and to make the trade-offs clear. What if you spend less in this you'll get less of this, or just to make it a transparent process and make the trade-offs very clear. And that's obviously where our role, I guess, as researchers ends and where the policymakers take over. I think just to speak to the root causes, and I'm sure Diego can speak that a lot more. I working in kind of the HIV structural drivers. What we found, what I found quite striking, is that we often think these things are so complex. They'll take so long to change. They're long processes. But actually, there is evidence that we have, that within programmatic timeframes, we have found effective interventions to change gender norms. So, for example, there's the SASA intervention in Uganda, which is a community-based intervention, which really addresses these power dynamics at the level of couples and at the level of the community. And that found, I think it was within 2 years it has a kind of a cluster randomized controlled trial, very rigorous evaluation. They found changes in gender-based norms. They found reductions in partner violence, past year intimate partner violence, so really incidents of violence. They found changes in HIV behavior. So, there was another one in South Africa. So there is evidence that actually we can change these things. So I think we should not stop ourselves with this. Complexity is there, of course, and sustaining the changes is another issue. But I think, there is actually something we can do, that can be done. Whether policymakers are going to do it, or going to want to prioritize that, that's something I don't think I can answer. But we at least have pieces of the puzzle, and we have elements that we of evidence that we can use to inform that process.
Other questions, comments? Maybe just to add to what you were saying, this is a 2-year project. So of course, in 2 years, you cannot change much in terms of the GBV prevalence rate in the communities we're working with. And you need to be able to measure and to capture what is changing, right? So we're not going to get SASA's results in terms of, preventing violence, but we will capture changes in attitudes, right? And the acceptability of violence in that community. We will also try to capture how the political actors and the decision makers, see the problem of gender-based violence and how their perception shifts when you bring the economical arguments, but you also bring, the social benefits and the political benefits of doing something that is also with a longer term time frame, right? So as Michelle was saying, these are pieces. I think what she presented is also very useful for other interventions we are doing, and particularly the one that the health team is leading on, and that the SDG accelerator labs on the ground will want to know how we made it at the local level, applying for the first time ever this co-financing model to a planning participatory process. So I'm pretty optimistic that we will bring something to the table that can be used and maybe taken further up by other colleagues and other projects. So maybe that was the question by Richard. I'm not sure if he clarified, but this is just one example of how you can use their methodology, their co-financing model, which we think is innovative and promising as well. So
Yeah, there's another online question from Natalia. She would like to know whether there's a plan on how to involve private sector players, for instance, health insurance companies.
Good question. I think at the moment, as I said, it's early days. We still have to do the mapping of the financing sources. I don't think, at least not in Moldova, I haven't thought about the health insurance. It is worth pointing out that some of the examples in the high-income countries do bring health insurers into that pool. Yeah, I think it will depend on our mapping. We definitely do. There's definitely a core part is to consider private sector funding. So that will be part of the mapping, and efforts will be made to kind of reel them in. Yeah, again, I would say watch the space. Hopefully we'll have more in a year or so to share.
Well, the idea is to have an expert meeting in Kuala Lumpur next year, in 2020, to bring together the different experiences and share the knowledge that we have gathered, and maybe also refine the model and think about the next generation of pilot interventions to test, our findings, our assumptions, and improve the overall model. So we're very hopeful that this is going to be an interesting conversation in Kuala Lumpur. Hopefully, many of you can join the preparations, and we will make sure that expert meeting will be live streamed and that people will know about what we are going to discuss there. So if there are no further comments or questions, let's see. Maybe, Roy, you can tell us when the guidance note will be published.
Well, I can't tell you an exact date, but I would expect it quite soon, maybe in a month or so.
Okay.
But yeah, maybe just a little bit on the guidance note. I think the logical endpoint of where all this goes, co-financing for HIV, co-financing for GBV, is of course co-financing for the SDGs. I'm always a little bit amused. I was telling Michelle, I was emailing with her, I'm always a little bit amused when someone hears, for example, that Zamba trial, and they say, oh, it's co-financing for health. It's like, well, no, there's schooling outcomes, there's economic empowerment, there's gender empowerment, you're reducing inequalities. So a lot of times it gets, typecast into a particular, bucket. And while that may be useful when you're sitting with the Ministry of Health to say, oh yeah, it's co-financing for health, I think billing this as a bigger, solution to the problems we're having around going from the siloed approaches of the MDGs to the integrated approaches of the SDGs is a great way to really capture an audience, a political audience that has accountabilities just onto that, like finding efficiencies, implementing the SDGs in an integrated manner. There's political capital just in doing that above, achieving your sectoral outcomes. So that's a way that we have to sell it. So anyway, our guidance note is oriented around getting this implemented for the SDGs. It's aimed at public and program planners in countries, policymakers, national economists in the UN country teams. And we spoke a lot about the challenges inherent in co-financing. And there's there's the technical steps are laid out in the guidance note, but there's a really long section on the political steps, to your point, trying to identify and overcome a lot of those political barriers. This exercise almost requires a mini institutional context to capture some of those attitudes and best windows of political opportunity. And the note, in addition to providing all of those steps, provides examples of where co-financing has worked. Some of those higher income country examples. Some of the work that we've done with the Strategic Policy Unit, where they've looked at Malawi and taken it actually a step above the project level to go straight to a Ministry of Finance and said, how much money would you allocate to different sectors? And what impacts could you have in a sector-wide economy model across the SDGs, doing a co-financing approach versus business as usual. So that's in the document as well. So we hope that, as Michelle alluded to, that the MAPS platform, it would be a strong delivery system to take this idea to scale. And when the co-financing was conceptualized, Michelle, back in 2014, 2013, we were still in that MDG era. We were coming out of it.
Yeah.
But what better time than now, starting with a whole new approach for the SDGs, and in that initial SDG period where people are kind of figuring out their plans and how they're going to pay and all of those things, to make a real big push on this. So we're hoping that MAPS can help accomplish that.
Absolutely, MAPS and other initiatives, for example, the Spotlight initiative, which is a 500 million euro fund to show results on ending violence against women, would benefit from those examples. The example from Malawi that you were saying is very relevant, because one of the 25 selected countries for Spotlight is precisely Malawi, right? So you need to bring that lens to your intervention in Malawi, which is targeting health services, which is about changing social norms, which is about preparing the institutions to cope with the problem. But if you add the financial component, then it becomes a very holistic intervention. So I think the guidance note will have a lot of demand in GBV project, and this is an ongoing conversation. So I would invite you to maybe think about other opportunities for us to share what's coming up from the pilots in the 7 countries, Spotlight, whatever is happening in Malawi with the SDG acceleration labs. Maybe also we can integrate them. So this is really the beginning, just to make sure that we are taking advantage of, as you're saying, the timing of this happening at the initiation of the SDG implementation, and also of the potential in terms of savings, in terms of efficiency, sustainability. So thank you so much for sharing and for co-hosting this event with us. Thank you to the Health, HIV, and Development team, to the Innovation Platform, and of course to Michelle and Fatima for making time and starting early, even though you're just fresh from the airplane. And this is to be continued. And thank you for all of you for attending.
Thank you.